we want to streamline and make sure that we have a consistent method of doing home quarantine across the divisions in Fiji, and essentially, if we go back to a bit of and the quarantine is basically just quarantine is to keep someone who might have been exposed to COVID-19 away from others, and that's essentially what home quarantine is all about. Okay, the scope of SOP on home quarantine. First, it is going to be used by the SOT, and there are monitoring individuals who are on home quarantine due to COVID-19. Secondly, it'll be used by the health quarantine officer. This is essentially for those at the ports of entry, and the team that are there that is monitoring individuals, international travelers who have recently returned from overseas, or persons whom have traveled between a containment zone to a non-containment zone. So, for example, if you're traveling from between Suva, then you're going to Nabua, the aspect of being on quarantine will apply to you. And thirdly, the scope is for the duration for the home quarantine shall be a minimum of 14 days from the date of arrival into Fiji. This is in the context of international travelers. The date the person has moved between containment zones, that's like if you're moving from Suva and moving to Nabua, or moving from Rotoka then moving to either Tavua or Ratiraki, or the date of person becomes aware that they have been in contact with a confirmed case of COVID-19. The fourth scope of this SOP applies to any individuals who is a primary contact, casual contact, or a secondary close contact. Now, all the definitions of this primary contact, casual contact, or secondary close contact would have been disseminated to the divisions. The definition is under the contact tracing SOP. Okay, applies to those individuals returning from COVID-19 affected countries and considered high risk, can be placed under home quarantine with approval from the CRMT, COVID-19 Risk Management Task Force, or other authorizing officer as determined by the CRMT. Now, that particular scope, the fourth bit, that applies to international travelers, okay? And the last bit of the scope of the SOP, any individual who is a secondary contact, immediate family members, or those returning from COVID-19 containment zones and considered high risk shall be put under home quarantine. I hope that is clear. Now, before going into home quarantine or establishing home quarantine, or even trying to put someone into quarantine, there's some prerequisites. There's some do's that should be you should check some boxes before you can allow some points. So these include you have to the patient or the individual has to provide a number, the physical or address of a place to allow ease of communication. There should be a guideline to be the guidelines has to be clear on the quarantine address. You should have sufficient gloves, masks, hand sanitizers for the screening team that will be doing the regular monitoring during the 14-day quarantine period. You should have a home quarantine guideline that is to be given to individuals that are under quarantine. The facility or the residential of the individual that is going to be placed under quarantine has to be close to a health center, a nursing station, or a subdivisional hospital for easy access by the medical team. Another important aspect of this is that the water supplied to the house has to be sourced by the Water Authority of Fiji. It has to be close to a police station or police post. This in terms for providing security should the need arises for places for houses that are being placed under home quarantine. Also, it has to be a single residential building with proper fencing. All sided, you should have a gate that can be used for entry and exit. Okay, and when requested, the individuals or the families that are being placed under home quarantine, you should be able to hire private security, not necessarily for everyone. So this usually applies for those that are coming from overseas. At front gate, which shall report daily to the health surveillance officers. And lastly, the last prerequisite is that other family members occupying the house shall not be more than 5 members unless the home can accommodate a maximum of 2 persons per room or sleeping for all household members. Now, remember, for most Fijian families in Fiji, usually 5 is more an average. So you have numbers less or more than 5. So the discretion of the team, the SOT team, this is where you use a discretion where the house can be used as a quarantine facility. Okay, the inclusion criteria. After you've done that assessment, the prerequisites after you've seen you've checked all the boxes. These are the inclusion criteria for the individual to go into home quarantine. First, the person has to be identified as a primary contact, casual contact, or a secondary close contact of a lab-confirmed COVID case. 2, persons that have traveled from containment zones in VT level to Borneo level or any other islands in the Maritime Islands or those in other islands in the Western Division. These are the inclusion criteria of those should be put under quarantine. Thirdly, persons that have traveled from containment zones to non-containment zones within VT level. So meaning if you're traveling from Suva or from Nosori to Naita City, you will be placed under quarantine. The fourth inclusion criteria here is persons that have returned from overseas and authorized to be on home quarantine. And you also have a criteria where the person that must be healthy and of a sound mind that has the resources to undertake self-monitoring for purposes of home quarantine. Person and household members are self-sufficient to an extent and have some level of external support from family, friends, church or other community-based support. And lastly, person's home is assessed and confirmed appropriate for home quarantine. Okay, this is the exclusion criteria. This is basically or at the discretion of the health team or the subdivisional outbreak response team with, in particular, the medical officer. The person is already a lab confirmed case. These are lab confirmed case of COVID because this will be a step up to home isolation rather than home quarantine. Person is displaying COVID-19 symptoms. Person is immunocompromised, such as those undergoing cancer therapy, those that might need regular dialysis or transplant recipients and may not be eligible for home quarantine. The fourth exclusion criteria, persons over 50 years of age might have other ailments, which might include being hypertensive, is diabetic, have heart diseases, might have a chronic lung disease, liver, kidney ailments, and other infectious diseases that might, that might compromise the health of the patient if being left on the home quarantine. These are people who will be evaluated by the treating medical officer and will be excluded from being under home quarantine. And lastly, the last is that a patient or household members who have mental, social, economic, and domestic issues that have that further endangers members or aggravates relationships during the period of home quarantine. We've had examples here in the super containment zone where we have partners fighting and even ending up to physical abuse during the home quarantine. And those are some of the aspects that we have to carefully assess and make sure that it's already in place, that you have to exclude them from exclusion from being under home quarantine. Okay. Health screening, monitoring, and retrieval. The subdivision outbreak response team shall conduct monitoring for home quarantine persons at a residence. Now, for those in the Western and the Northern Division, you are talking about the parts of apart from Nandi and Lautoka, other subdivisions, and the whole of those from the Northern Division. You are a very good place right now to make sure that you go through the fundamentals of home quarantine that we are showing in, and also those that will be included in the SOP. So the SOP shall conduct monitoring of home quarantine persons at their residence. 2, symptomatic persons shall be swabbed and tested immediately for COVID-19. Should the test result be positive, the person shall be retrieved to hospital or community isolation facilities, and other household persons shall be quarantined at home and monitored closely for symptoms. If during routine surveillance an individual shows any symptoms, then they have to be swabbed, and if sick, then will transferred to an isolation facility, or as I've said earlier, a step up to converting the home quarantine house to a home isolation within the home. Again, it has to be appropriate. And lastly, if not sick or has mild symptoms, then the individual stays in quarantine and waits for results. Okay, this is basically a flow chart for home quarantine, for those that are being placed on home quarantine. It also includes some aspects of international travelers. Okay, first of all, there has to be a closed, casual, or lab confirmed case, or a person arriving from overseas, or a person that's traveling between a containment to non-containment zone. Okay, and for individuals that are like a pre-flight or about to leave Fiji, Fiji base remains in a home or facility or quarantine facility while awaiting result. We'll go with a positive arm first, the one on my right. So if a person tests positive on the entry swab on day one result, the pathway that they follow is that the patient is retrieved as per retrieval and transfer SOP. You'll have to refer to relevant home, community, or isolation facility. Now, in the context of the central division, this might differ because they are in a different level of they're in the mitigation phase now. But for those in the western and the northern division, the more you stick close to the fundamentals of the quarantine, the better the outcomes will be as we move on during the outbreak. And lastly, once the patient has been retrieved, the personnel may be referred to a community home quarantine SOP, and then that triggers the decontamination of your home, which will be then has to be left empty for a period of 48 hours, and then it can be reoccupied. So that's for a positive case. For negative case, if your day one result is negative, the person is assessed for suitability to home quarantine. If they are determined to not eligible following assessment for quarantine, then they are being referred to either a hotel quarantine facility or a community isolation facility. If the person is determined to be eligible for home quarantine, then they undergo 14-day quarantine that will be initiated. They'll undergo the test of day 1, day 4, and day 14. Then you have that retrieval team where you will do the home monitoring. When you do the home monitoring, you will do swabs, and if individuals become symptomatic, you'll isolate from others within the home. If it tests negative, but the last bit of this, hold on. If it tests negative, you discontinue home quarantine following negative exit at day 12 result. I think it's not shown in this, but if it tests negative, you discontinue quarantine. But if it tests positive, it's and then again the clinical team, they do the assessment, and they are retrieved to be taken to the isolation facility, or you step up the quarantine, home quarantine, to be a home isolation facility. Thank you, ladies and gentlemen.
So, Naka, so once again, colleagues, if you want to ask any questions, feel free to use the chat. If not, you can hold on to your questions, and then at the end, during the question and answer session, then we can receive your questions. But we'll move straight over to home isolation. Dr. Eric Rafael will take over here.
Thank you, Joe, Dr. Alipati. So the reasons why we are presenting this presentation is isolation follows when a diagnosis is made or a test result is positive. So when this was prepared some months ago, it was focused largely on isolation during containment, and hence much of the presentation of this will be about isolation during containment, focusing on stopping the spread of disease. The advice given on isolation ensures there's no ongoing transmission, and it's different. Must acknowledge that since central division is in mitigation, there's a difference in the home-based care monitoring that's conducted during mitigation, where the primary goal is to identify those that require more intensive care with oxygen And during this mitigation, it will be presented hopefully as an SOP later next week. So the purpose of this SOP is to outline conditions for isolation of a person with a diagnosis or a laboratory confirmed result, either at a home, appropriate home, or rented accommodation for the duration of the infectious period. So this is similar in scope and the inclusion and exclusion criteria to the home quarantine. And except that in this case, you have a diagnosis or you have a test results and you have a mild symptoms and you are basically trying to recover at home without medical care, but you have access to medical supervision if your symptoms escalate. So it's basically you're minimizing any potential community spread as you are a confirmed case, either to immediate members or to anyone living in the community. And it's presumed that you've had some test confirmation. So elements of this SOP may apply to persons awaiting laboratory confirmation of COVID-19 infection while in home quarantine. So the prerequisites are quite simple, quite similar to the home quarantine in terms of contact details, guidelines on home isolation, and these are guidelines where look at PPE for the screening team, looking at what guide you need to give to the person involved in terms of self-reporting, in terms of home-based care. These details will come in subsequent SOPs. You consider the proximity to a team that's going to monitor the home isolation, whether nursing station or hospital, where there's easy access for the team. I think the other bullet point that was raised by Joe on water authority is basically looking at the utilities. At least should be looking at the utilities that, it has been paid, bills have been paid, and so that when in home isolation, there's no need for any contact with any outside authorities. It could be close to any of the enforcement agencies, could be a single residential building with proper fencing or just one front gate for entry and exit. These are just some of the points considered by authorities, looking at whether you have police guards or authority. It depends if you have a gated community. There's different definitions for accommodation. And other members occupying the house may, like what Joe has mentioned, may not be more than 5 members because of the way our people live in the different divisions. Next slide, please. So this has been mentioned, but slight difference, asymptomatic patients. So in the inclusion, you're looking at someone with a positive diagnosis, either by lab or by clinical. They may be asymptomatic, most likely asymptomatic, and has been assessed, determined by healthcare worker. So I want to emphasize, I think one key principle is that there is a medical assessment in the beginning of the patients to decide on whether they're appropriate for home isolation, especially in the containment phase. So those with mild symptoms who do not have the comorbid conditions like NCD factors, they don't require to visit clinics frequently or dialysis or things like that. They are healthy, fit, and have a sound mind, especially, the period of isolation, living on their own, have some responsibility in terms of self-monitoring, if possible, and have some caregiving for dependents, children, especially breastfeeding. Patient household members are self-sufficient. I think this is the ideal situation, but as we know, government is providing support in terms of providing rations to members who have decided to go on isolation. And in some instances, there are some external support from family and friends. There is no contact. There is just a drop off of food or other needs at a located spot that the members will the persons on isolation will pick up at a later stage. So patient's home is assessed and confirmed appropriate for isolation. I think this is key. The two assessments I want to emphasize. One is the clinical assessment, medical assessment by a healthcare worker. And the second one is the actual environment assessment by either a health inspector or the SOP team. Next slide. So exclusion criteria, again, is similar as before. We have the standard exclusion criteria that you see in some of the guidelines. Immunocompromised patients, those over 50 with comorbid conditions. And I think the third one was something we've just added from our experience, is that if you have some issues, some mental, social, or economic domestic issues, it's best not to put them on home isolation, especially in a confined period, in a confined space for a long period. So this is basically the summary chart. So you have a confirmed diagnosis, and the members are tested. This is during containment, and then you have the medical assessments. Not eligible. In the containment phase, initially, if you had symptomatic or if you are comorbid condition, if you're in the exclusion criteria, we would have just sent you to a community isolation facility. Now, this is slightly being changed to with the mitigation phases, and we're talking about the containment largely. So eligible asymptomatic or with mild symptoms, conduct a home isolation assessment, and then you determine if, based on the home situation, the environment situation, again, you determine if it's eligible or not eligible. So the first assessment is always the clinical or medical assessment by the healthcare worker. When I say healthcare worker, it can be a doctor or a team, a SOT team that has a nurse or some clinical person within it. And then you go through the phases of the monitoring, either alternate or regular monitoring, and then discharge. Now, what's important, it has been determined that, you don't have the same frequency of testing as for quarantine. You, in the mitigation phase, or in this containment phase, I think you are discharged without a test if you are asymptomatic, if you do not have any symptom in the last 3 days or 72 hours. Now, some guidelines will say 48, but we are using the 3 days of your confinement in isolation. Next. So these are the ways of monitoring. More details of this will be available in the next SOP discussion with home-based care monitoring. And there are options, several options. Now, what's important with these options is that it depends on the cooperation of the patient concerned. It also depends on the economic ability or the ability to sustain themselves over this period. You have different communities in Suva. You have people in the informal sector, and then you have people in high-rise apartments with very gated communities that have their own internet. They are working from home. They can do their own self-monitoring, while you have communities, individuals in informal sector that needs close physical monitoring or some form of monitoring that equates to that. You also have, now what they're using a lot now with the mitigation phase is the telephone contact. But then again, we know that not everyone has a phone. You can also use a self-administered questionnaire collected by a healthcare worker. So that's the reason for these options. There are several options, depending, again, determined by the assessment of the environment and of the person concerned. And violations, I know there's some infringement notices that have come up with the new regulations. I'm sure Joe can provide further information on that. Daily monitoring is reported in a standard form. Or next. This is just an example of a follow-up form. I recognize that the divisions have their own forms during the containment phase, but there is some element of filling reporting, either self-reporting or calling patients by phone to ask about symptoms and any other issues that they may have. Next slide, please. I think before I end, I just want to add there is also a declaration component that they will abide with the home isolation, and I think this is again further strengthened with some notices related to the regulation, and I think Joe can provide further details on that. Thank you, and thank you, Dr. Alepati and colleagues for listening in.
Okay, thank you for the presentation, gentlemen. We'll probably start off with Mr. Tambua. We had received some information via social media of all things about a food drop that was supposed to take place at a particular home where they were supposed to be under isolation. I'm not sure whether the person was positive or a first-degree primary contact, but anyway, they were taking food, and then they got to the house and they realized that the house was empty, and the person who was supposed to be quarantining or isolating at home was actually in town buying food. And so you mentioned something earlier about infringement notices. Could you maybe shed a little bit more light on that?
Thank you, Dr. Alipati. So on the 8th of July, the minister, he signed the commencement notice for these public health, it's called infectious disease infringement notices. So indeed, it has a lot of these the fixed penalty notices and the offenses that are tagged to this. And one of it, it's under legal notice 52. I'll put a link through to so you can share it, Dr. Alipati. So in the context of that individual breaking home quarantine or home isolation protocols, they will be issued. He will be issued with a fixed penalty notice, something like what the LTA has, or even the traffic police. If you're overspeeding, the same kind of notice. So it's a spot on fine. So it's an offense under the new amendment that has been made by the minister under the act. And for you to break that, protocol or breaking the home quarantine or home isolation, it has a fixed penalty of $200, and it can go to a maximum of $10,000 or a period of 5 years imprisonment.
Okay, Mr.
Thank
Tambo.
you, Dr. Alipati.
So, Mr. Tambo, who actually polices this? Is it just the police, or can medical officers or medical staff also give out these infringement notices?
Thank you for, so in relation to the public health act, so there are two personnel there that can do this particular. It's the first is the health inspectors and also the medical officers. But we are having discussions and also apart from those two health professionals, you have the police on the third side that's also doing the policing bit in terms of enforcing this particular regulation. But we are in just today we were discussing with the honorable minister on how we can expand out to other cadres within other ministries or within the ministry on the responsibility of training people on how to issue fixed penalty notice, because we can have that wide coverage of making sure compliance to our COVID-19 safe measures. So essentially, it's the medical officer, the health inspector for now, and the police.
Mr. Tambua. Colleagues, if you have any questions for the two gentlemen on home quarantine and home isolation, feel free to place it in the chat, or you could unmute yourselves and ask questions. We've got a comment here from Dr. Krupali. Many patients in the Suvarnasari corridor who have been in self-quarantine, if they have any symptoms and won't be tested unless high risk. Many people are not compliant with these rules. So the question is, how will it be monitored or regulated, as we could have many symptomatic people walking around with COVID, potentially spreading the disease? So I think what she's trying to ask is the fact that we're not testing anymore, and people are being asked to quarantine at home, and how we're going to monitor that if we haven't, if the particular family or quarantining group, quarantining household, if they haven't actually got any tests but are quarantining at home, how is that supposed to be monitored? That's a very good question. Mr. Tambua, sorry, putting you on the spot here.
No worries, Dr. Lepadesi. The issue about the containment zone in Wainandoi and Longani in Subano Surilami, we are living in the moment, in the current outbreak, and but we do not want to be the prisoner, want to be a prisoner of the moment. We are trying to evolve how we can identify this, and we know places, for example, that constant cause of major influxes in the cases. We talk about supermarkets, we talk about public places, funerals, yeah. These places are places where we can be able to catch those who are might offending. And I totally agree with Dr. Kurpali. It's a cumbersome task, and but again, we have to continue trying to get hold of these people and try to get them fine. As much as we try to do that, and because of not much testing is being done, we are only not so much. We are only the losing side. But for those in the Western Division, in the Northern Division, you have the benefit of hindsight, and you can learn from what because we are living in the moment. You can always benefit from what you're looking through the lens of the moment. And as I've said, alluded to, you have the benefit of hindsight, and you can start now from where your cases are very low and build up on these quarantine measures and the enforcing of these public health infringement notices. Thank you, Vinay.
So maybe just to make it practical, say you've diagnosed the patient with COVID, and he's going home and he's isolating, you know his family, and then you're walking around town, and all of a sudden you meet that patient in town. So practically, I mean, they are violating the law. So how would a medical officer practically issue a infringement notice? Are there like those tin books or something that the LTA officers walk around with? How does this happen practically?
So yes, you'll be issued with tin books, and if you have evidence that the person has been swabbed and is positive of COVID-19 infection or is under home quarantine, then what the police is doing now, they take a picture of the person either in a public place or where they're not supposed to be, if they're not at home. So that is admissible in court as well. And if the person wishes to take that further to court, but that is an evidence that the person is not in a quarantine place. And just to add on to that, if you're talking about the issuing of fixed penalty notice, with that book with you, you issue immediately to the person on site. And it's always advisable that you do it like what we do is we go in, you have buddies, doing buddies. So one is there as a witness and you issue your fixed penalty notice.
Look, I think that answers the question from Mr. Sen, who said that some patients who have been advised on home isolation by the ministry are visiting general practitioners. So I guess that'll answer your question. If you know that they've already been advised to remain at home, to quarantine at home, maybe take a photo of them, and then they could be issued with the infringement. Naka, does anyone have any other questions on home quarantine or home isolation? So again, from Dr. Krupali about patients in the West, businesses in the West whose staff have symptoms, and the staff are being asked to isolate at home. The staff are struggling to get tested and creating many issues for the employers. So how will this be managed? Another good question. Dr. Rafai, do you want to go with this one? How are we going to manage the continued testing in the West of patients who may have symptoms?
Simple answer. They have screening clinics. They should be coming to those screening clinics for testing, because this element of having symptoms, especially if there has been a contact within the factory or history of becoming a primary contact. I mean, that story is not full. They need to be tested, either going through a screening clinic. But once you show symptoms, it needs to be determined at the screening clinic by a healthcare worker, whether it's COVID-19 related or whether they need further testing for COVID-19. Yeah, I understand West is having issues with testing, largely because much of the testing is confined to the divisional hospital, and some of it is sent to central.
It's a bit difficult for the public if they've been advised to stay home and quarantine, and one of them becomes symptomatic, and they're calling the number, and for teams to come and swab you, and they're told, oh, you need to present yourself to a swabbing facility. You're technically going to have to break the quarantine protocol and leave your home to travel, maybe in public transport, to a swabbing facility. So it's sort of you're going against your our SOP again in order to get swabbed. Yeah, it'd be interesting to see how we can sort that, other than trying to create teams to go around and swab everybody, which is probably going to stretch us thin already. Yeah?
I just want to add, I've added in the chat, I think, some of the information that's given out needs to take into context on where are you located. That's why I asked the question to Alepati. If you're in the central division, we are going through the mitigation phase. As soon as you walk out of your house, you're already a contact of somebody, because the infection is within the community. That's why there's community transmission. While in the West, depending on where you are, there's certain areas still in containment, largely containment, where we are applying these SOPs that we are discussing now. And next week, we'll be looking at home-based care monitoring. And that's where we are. I think you need to look at it in that context. If you see some of the information coming from the ministry, that's why there's always a reference to the Suva-Nusori corridor in terms of the mitigation phase, where there's active community transmission.
I'm just sharing this slide again for next week's presentations and next week's webinars. Okay, we have a question here from Dr. Reina about students living in dorms using shared facilities and needing isolation once they start showing symptoms or become positive. What is the advice for them? Yeah, that's a good question. So I think she's referring to maybe, for example, students in maybe USP in Suva. How would they, what would be the advice for quarantine for them? Because I understand like their dorm doesn't really fit the inclusion criteria for home quarantine.
Dr. Lipari, is that for USP students?
Sorry, Joe, you're breaking up?
Oh. Is that for USP students? Is that for USP students? Is that for USP students?
Sorry, are you saying, are they fully vaccinated students? Say, what if they're not? Just assume they're not.
Yeah, I mean, the current advice is, in Suva, if they are showing symptoms, they need to be isolated there. But again, isolation also refers to, again, the measures that need to be undertaken by individuals. They still wear a mask, they still do anniversary, and it's also, I don't know about the EH component of it, the environmental health, but I think Joe can mention about the separation, about when they can use the facilities and all those other details. Joe?
Thank you, Dr. Rafa. I see for institutions like for USP and FNU, you have the benefit of having medical facilities next to, like GPs next to the men who are responsible for the students on campuses. And for dormitories, if you are in your room and if USP wants to convert that into, that's a very ideal quarantine facility because you have separate rooms. So we have a home, it's a quarantine SOP. Whether you are in a quarantine facility SOP, so once they declare one of those buildings, if they want to use it for as a quarantine facility, we get a health quarantine officer. We can get security, either the USP want to use their security, or we can get ours. We use the military to support the quarantine facilities, and probably one or two, if they have a nurse here, or we can even get a nurse to assist in managing a quarantine facility should they decide to dedicate one of their dormitories at the USP to be quarantine facilities.
So yeah, I guess we could use USP, but they'll probably need to get in contact with the ministry to try and I guess appropriately manage their students in the dorms. This is an interesting one about the Fiji Care app. Especially in the central division, whether its function is still valid or not, because we're just telling everybody, if you're symptomatic or you come in contact with someone who's symptomatic, then you just isolate. Gentlemen, do you have any, what are your thoughts on the Fiji Care app in the central division right now?
Yeah, the Fiji Care app is largely we've always advised it from the beginning. We still do the traditional contact tracing. The Fiji Care app is meant to support that process of contact tracing. It's more of a record. You take it like it's a recording of where you've been and who you've been in contact with. It is not useful if you have not been in contact with anyone. However, there are some limitations also. If you are within a confined space like a dormitory and you remain in your room for long periods of time, it will still read the other people in the next room, even though you have a barrier there. So I think the use of the Care Fiji app must be used consciously by understanding how it works, rather than saying, oh, it doesn't work, or it works. And it's really up to the technical people who use the contact Fiji, like, for example, the teams like the contact tracing teams. It has its use, but it usually is not part of the traditional way of doing contact tracing. And that was the purpose it was designed for. It's really a record of who you've mingled with, and that's it. Yeah, it doesn't, it depends on the context and the.
Thank you, Dr. I'd just like to add to that. Moving forward, as the cases will start to de-escalate and moving, this is a behavioral trait that we might institute into people where we enter premises. We will be able to get a record that you were in this premises as the cases de-escalate and moving forward, like years from now, 2, 3, 4 years from now. It's an app that we can use to successfully trace people who've been to places that we would like to link to cases. Thank you.
Thank you. Another question from the West about patients who are visiting fever clinic but are going home with prescriptions. They're not being swabbed. How can this be addressed? I think the fever clinics themselves should have their own SOPs on who fits the definition for swabs and who doesn't. Yeah, so I think that's how we can sort that. Another question from Dr. Lai.
Can I just mention it? Yeah, can I mention Dr. Alepati?
Go ahead.
I have to thank, I have to acknowledge yourself, Dr. Alipati and Liz, for organizing these SOPs. This is one of the major issues that is impacting the medical community, is that we have these SOPs and it's not trickling down to the various levels for people to read and use it, and hence this webinar. And if everyone understands the SOPs and the changing nature of the SOPs according to the different phases, will help people understand. This is an issue we had identified some months ago, where some of our staff that were contacted sent to fever clinics for swabbing, and they said they don't fit the criteria. So it is a problem that has been there, but I think when this kind of activity where we have webinars and explaining about the SOPs, people have a better understanding. Thank you, Dr.
Dr. Laila is asking about a home isolation guideline that's available to patients. Yes, it is. There is a home isolation guideline. It was released a couple of weeks ago, and we can share that with you. I think you've given us your email. It's on the Ministry of Health website also. It is, I can remember, it's blue in color. But it is, yeah, there is one. There is one. Please don't make your own. There is one, and it's based on the SOPs for home quarantine and home isolation that have been discussed today. So it's just a summary, and yes, you can get that off the website. Dr. Karti.
I'll try and attach it here.
Okay, thank you. Awesome. For those that are working and isolating at home and are not swabbed, is there any certification that can be given that they can provide to their employer? Yeah, this is a very good question, especially for here in the Central Division, where the new advice is if you've got symptoms, stay home. And that means that there's a possibility that people won't be tested. So how can they provide certification to their employer? That's a very good question. Somebody might take advantage of it. Gentlemen, anybody want to take a swab at that?
Yeah, I just want to report on this was discussed, I think, this morning with our senior managers, and I think there's some comms coming on about this. Was the issue was with workplaces, workers who are self-isolating and need something for work. They will be asked to also they'll be asked to come to the screening clinics to be assessed by a medical officer who will determine if they require the required sick leave, and just to confirm and verify that they have a diagnosis of COVID-19. That's the advice we received this morning, that they can use with the employer, because confinement of the 14 days.
Just another question here about, I think this is with regards to the exclusion criteria for home quarantine. Yesterday, Dr. Alicia was on and she mentioned that one of the high-risk groups are actually the pregnant mothers. And I think the question is whether the pregnant mothers should be quarantining at home or whether they should be sent to a medical facility because of their risk of developing severe COVID. Oh, cool. We got Dr. Amanda who has answered that. Any pregnant woman who is COVID positive should inform their primary ANC or obstetric team. And I believe the team will decide from there. Thank you, Dr. Amanda. Dr. Amanda, do you want to highlight this or do you want to speak to this point? Kerkere? Dr. Amanda, please. If we have any other obstetrician on board today, I would like your advice. Should all our pregnant mothers be isolating in a medical facility? Yeah, we've had like, I think 4 obstetric deaths from COVID already. So they are definitely high risk. Go ahead, Dr. Nigel.
Bulvanaka, Dr. Patty, thank you very much to everyone who's taken time out on a Friday evening to join us. I'd just like to make a comment in support of Dr. Eric's comment around SOPs. As you said, these are living documents, they change, but they're only of value if they're shared properly to the workforce right across the system. We have had numerous occasions, as you know, Dr. Pate, where people on the ground didn't know an SOP existed, or they worked in isolation of others. So we're working hard to get some sort of coordination around this. But, you know, so it's very important. These are basically rules of engagement, not just general guidelines, and they should be followed quite clearly. And also the other thing is we have to build into our systems ways of ensuring that people are working in compliance, that they have some monitoring systems. And this is particularly important around the IPC and the use of PPE. So it's just really to reinforce that point. Thank you.
Can I just add also that, you know, there are several SOPs. So we are just covering one aspect of it. There's this home-based care monitoring is another element. So, you know, if you piece it together, they all make a better picture on how we can respond.
I think this question keeps coming up about where the patients are going to get certificates from. I guess once there's been a decision on this, then we'll disseminate this information.
Let me just add, the reason why they need to be seen by healthcare workers was the concern raised by some within the medical fraternity that just informing the employer that, oh, that you have symptoms and you are staying home, it's not a very verifiable condition until it's seen by a medical practitioner. So I think to get that medical certificate, you require a medical practitioner to verify your condition as either, where you have symptoms.
Sorry, just adding on to that, Dr. So from a GP's perspective, just answering that question, because I had a patient today came, she's gravid, she's probably 3 or 4 months. She came symptomatic. Her husband was recently symptomatic and had recovered. She came in with her 1.5-year-old, also had a fever and just a bit of a runny nose. So as per the directive from within the last 24, 48 hours from the PAs, exactly what I did. I told her self-isolate for the full 14 days, but only because she's pregnant, I advised her, look, given that she's high risk, get yourself swabbed. If it's positive, that's fine. But either way, she's still going to do the 14 days because anytime from the first day she swabbed till the 14th day, she could become positive anytime between there. So the information, yes, they should be visiting a health center. And I think, or GP's setting, but I think it depends on, like you said, PPE, whether you can, you know, manage to look after yourself well in that area. You can see these patients which look very like COVID. If they want or they need, they must get the testing, then fine, send them to a screening clinic, which is what I advise them, but not necessarily does warrant. Yes, if they call in and ask for a certificate, I don't think that's something wise for a GP to do. Even if you've known your patients for 20, 30 years, they should be seen by, whether it's a GP or I think a screening clinic. It's not hard and fast.
Thank you, colleagues. We're hitting 7 p.m. now. Thank you for the very interesting discussions. So once again, thank you, Dr. Rafai and Mr. Tambua for joining us this evening. Ladies and gentlemen, remember tomorrow at 11 o'clock, we have that session on classifying DCs for COVID patients. And once we've confirmed the links for next week's sessions, we will be sending them out to everyone. So thank you again for attending our webinars today. Stay safe, enjoy the weekend, and God bless until we meet again. Vinaka.